Dr. Sue Mann realized she was pulling women out of a river. For years, women had been telling her, I just don't feel like myself anymore. She treated them one by one until she looked upstream and saw someone pushing them in. Today, Dr. Mann is the NHS's first ever National Clinical Director for Women's Health. She's not treating symptoms. She's dismantling the systems creating them. And women's health is at a tipping point. Gaps, long waits, years of being dismissed mean the system is still failing millions. What Sue is building shapes care, treatment, and everyday lives. So whether you're a woman who's felt ignored, a clinician who wants to do better, or a leader ready for change, this conversation is for you. I'm Penny Triantafillou, and this is Women Leaders, Tales, Trails, and Truths. So Sue, a very, very warm welcome, and thank you for being with us here at this beautiful space in Warwick Business School's London base. Thank you so much.
Thank you so much for having me. I'm really excited about this conversation.
Oh, so am I. I just love the metaphor, pulling women out of a river, then realizing, someone upstream is pushing them in. And you're still seeing patients, aren't you, while doing this national role. So what makes you realize that treating individual patients is just not enough?
Yeah, I mean, that metaphor is so good, isn't it? And it wasn't my own. It was coined by Irving Zola in the 70s, and he was a sociologist. But for me, it chimes so much. And I think, being a clinician, first and foremost, that's where I grew up. And actually seeing patients, which is, at my heart. I would never want to stop doing that. But, after a while, you see the same issues time and time again, and you do patch them up. And you do start beginning to think, I wonder why and how that problem has got so bad. And why am I seeing this person at a stage when we could have done so much more earlier on?
Yeah, was there a particular pattern that you were seeing in women's health, or was it just generally?
So, I mean, my interest has always been around women's health, and I could almost, every patient I see, I could almost take and go, work this back, actually what has happened that has led them to this point. And, most of the time, there are situations and contexts that create a crisis. And of course, in, secondary care, you only ever really see someone in crisis.
I understand. And so, talking about that metaphor again, what are you trying to build upstream to, kind of stop this?
Well, I think, in public health, which is part of my training, we learn that only 5% of health is determined by healthcare. And, if you put all your energies into that, you're not really going to get to the heart of it. And so, and when you look in sort of public health terms, the things like the social determinants, so the way people behave, the context within which they live, the poverty, the worklessness, the education, these are really sort of much more important things. So I suppose, what I'm trying to do is reconcile both the clinical ends, but also saying what else can we do, both supporting women in their context and of course against kind of a culture of sexism, and how can we support them to be empowered to manage their health better and to utilise a very functional health service so that, we all work together. It has to put women at the centre, doesn't it? And then wrap the care around their needs so they're not going from pillar to post and trying to find something that doesn't work for them.
Yeah, and I mean, you might see women coming back many times, third, fourth, fifth time, same problem that could have been prevented. I mean, what does that feel like?
I suppose, it feels like a failure. Or you see some women turning up in emergency care. And, if someone turns up in emergency care with a problem, it's because it's got to a really difficult point. So, a good example would be someone who had terribly heavy periods, who might have, their iron levels are in their boots and they can hardly function and they're very worried about the amount of bleeding. And you're saying, well, there is so much more that we could have done here. And maybe they hadn't sought help before because they didn't know what. They've been told periods are normal. They didn't know where to go. They might have been dismissed. There's all sorts of things that contribute to that one encounter in the emergency department.
So what you really would love to be able to do is not have them come back that second or third time by addressing it much earlier.
Yeah, for sure. And you know, some of that is prevention, but also some of it's early intervention, you know. So, and another good example is something like endometriosis, you know, and we've heard a lot about that in the media, haven't we? And it's a horrible condition.
I mean, is it true that sometimes a woman doesn't get a diagnosis for that 6-7 years later?
So I think it starts with a painful period and someone repeatedly going back to the doctor saying, I'm having painful periods, and being told they're having a period. And that's a normalised thing. You know, women's pain has often been normalised, I think, and then eventually sort of working their way towards a diagnosis, by which point we know that endometriosis gets much more severe over time.
Exactly.
So time is of the essence in a way.
Let's talk about that whole person care, because I listened to a video you did, I think it was in April, and you said it's important not to see women just as a product of their hormones. What does that whole person care look like in practice?
I think hormones is a really good thing to use as an example, because I see a lot of women, like, well, at both ends of the spectrum. I see young women who often feel hesitant of using hormones in their early kind of years, and then I see older women who are thinking about using hormones to manage things like the menopause. And I think if I look at that group of older women, and I think sometimes, and I think, you know, some of this is around the way that the menopause has been talked about, which is a really good thing. The menopause has been sort of brought into the spotlight, which I think is good. It's been normalised. But also I think alongside that has been this focus around hormones being this magic bullet. And there's no doubt that hormone replacement therapy is brilliant for some women. But, you know, often at that time of life, women are experiencing all sorts of very complex things. They're often you know, if they have a job, they're likely to be at the sort of top end of their job. So their job is likely to be busy.
Demanding.
Sometimes they have, you know, women have often traditionally been the carers, and I think they do still take up the bulk of that role, we know. So they might be caring for elderly parents, they might be caring for growing up children. And they're also facing a shift and a change in their kind of what they want for their next stage of their life, which, if we're honest, is almost half their life. It's not just the end, and that's how it used to be seen. And so I think if we reduce that just to hormones, we're not doing people a service, are we? We say hormones might be a help in some of that change, but actually we're going to need to look at this more broadly and understand why the experience is as it is. And if we get that bit right, then we'll give hormones to the right people who are going to benefit. If we think hormones can solve it all, we won't. Some people go, oh, this hormone, you know, hasn't done anything for me. And often now, I suppose the more women I see, the more able I am to think, you can try hormones, but I'm not sure it's going to be the thing that's going to make a difference for you. And I think I sort of feel better able to predict when it is and isn't going to make a difference.
So is there a story that, you know, you can share, no names, but a woman who's actually come into your office and said she's lost confidence or it's really affecting her? I mean, what was happening to that person? Can you give us a bit of a story behind that?
Yeah, I mean, I suppose, you know, I have an interesting group of women who come to me who've often had a breast cancer diagnosed, maybe in their early 40s. And the treatment of breast cancer is very brutal because it puts women straight into a menopause. And actually, it does that because we're trying to remove hormones. So, you know, you can't put them back. And so, you know, those... and I have a number of them that I see in that situation. And I find them, one, very challenging for me to manage because I don't often have my medical solutions in my toolbox. I'm limited with what I can offer. And I suppose they're not always looking for a solution. They're often looking for a place to put those very, very difficult pile of things that are happening. And we can look at each thing and we can find part medical solutions to them individually, but also look at the whole and just hold people, I guess, in the sort of, I hear you, there are some medical things you can do. Obviously, you can't do this because, or rather, you maybe wouldn't be advised to do this, but if in the end you decide that you will, then there's another conversation to have as well, because I think as doctors, we can overuse our power. And I think if we feel that someone is really able to hold all the knowledge that a treatment has, with all the risks that it brings, and you're satisfied as a doctor, and I can say this because I'm a bit older, because I hold the risk, but in the end, if someone says to me, my life is not worth living, and I'm prepared to take quality over, that risk, I don't think it's my place to absolutely say no. I can say, well, no one would ever recommend this for you. But, we have to give people back their power, don't we?
I was just going to say that you're empowering them to take the next steps.
Exactly.
I mean, but that must be a lot of pressure also on doctors who are holding all of that knowledge and the responsibility. But you're kind of passing it to the patient and say, what would you like to do? What's best for you? Is that a right?
I think as doctors, we're always holding risk. So everything you do, you're holding risk. And I guess as you get more senior, and you see the more complex people, and you also manage a team of people who you are defending their decisions, you're holding a lot of risk. And so, you get used to what that brings. And if you do everything you do with the best interests of the patient at its heart, then I think that you can easily defend that. And it's easier for me to say as I get older and more confident and more, with more experience behind me. So I will be probably much less risk averse than my junior staff will be.
That's interesting. I wanted to go to this part here about you wearing many, many hats, from clinician to national leader. Thinking back, what was the single most difficult challenge or setback that fundamentally changed how you lead today?
Yeah, so I have been through a number of kind of policy roles, and I've sort of wormed my way into where I am today. That sounds awful, doesn't it?
No,
wormed
not
my
at
way
all.
in. I've
You've
strode confidently into
in.
my way in. But there was a time when I was working at a policy level, and I was working more from a sexual and reproductive health side of things, but I was keen to bring the kind of whole person, whole woman experience into contraception care. And I had done so much work around making a case for that and how it could be done, and everyone had I thought I'd brought people along with me. And then at the last moment, the policy person just went, no, we're not going to do that. We're going to just do contraception. And it was quite a key moment for me, because I was just like, I don't believe that's the right thing. But also, I haven't brought people, I have to take some responsibility here. I haven't brought the right people along with me. I brought a lot of people along with me. But why is that? What is it about the strategy? And, what are the levers that I can pull in the future? And a lot of things are about timing, and a lot of things are about the political process that is utterly out of your control. So just seeing things happen and sometimes going, that's not a battle I can win. Here's an opportunity. Let's utilise that, So there's a lot of learning there, I think, to feed your way along the system.
What advice, so based on just what you've shared with us, and thank you for doing so, what advice would you give to a younger leader who's also trying to make a change and needs to bring people along?
Yeah, I think that the thing that I see in young people who are trying to lead is a lot of, and particularly, if I think about the medical profession, we've done a lot of burrowing into the books and coming up with the evidence and coming up with a lovely story. And actually, change is really about relationships, relationship building, making people feel ownership. There's a lovely, little video about leadership, which I'm sure you've seen, but it's about a guy doing a dance on a hill, and he gets some people involved as his first followers. Exactly. And, that was a really impactful piece of learning for me. Surround yourself with people who share your vision and get them to be driving that vision, not you. Don't necessarily put yourself at the front of it. Allow other people to put their stamp on and take it forward. And, if you can get someone who's very powerful and has a good sort of mouthpiece to take it as their vision, then you've done a good thing. That's a really good bit of leadership. You know, not taking the credit, this is my piece of work and it's all done and dusted. Look, here it is as a lovely document. Everybody's going to want to do this because why would they not? And your arguments might be perfect, but your execution isn't.
And that's where it all fails. I mean, I love that video. I watched it while I was in a course in the same lecture theater.
So good,
just
isn't
getting
it?
that one person, the one follower, and then everybody else joins.
Everyone starts to commit. And then you get your
brilliant.
stragglers, don't you, who may never come along, but they'll have to. Or they'll just have to watch, you know. So
you're very humble, and you don't want to take credit because I know the work that you've done. But what you're saying is, let's get people to advocate and let's get a shared purpose.
Yeah.
And just get people to champion, and that way we'll grow. Is that a correct?
Yes, and I think you can be too humble. You know, I think as a leader, you do sometimes have to stick your neck out, and you have to say difficult things. And sometimes you'll get those wrong, and sometimes it will bite. But I think, you know, if you're too woolly about it and it's just a bit like, well, we've all got to be collectively responsible, you also won't get change. So there's a delicate balance there, I think.
There is. Can you think of a time when somebody or perhaps even you were too woolly?
I think over time, I think that, you know, I used to be more woolly than I am now. You know, I've started to, and, you know, don't get me wrong, I'm lucky I have a platform. So I think the other thing is, you know, what can you afford to do given your role? And role is important, and I'm very lucky that I have a voice. And, you know, I don't always use that voice in a conventional way, but I do have the platform, and that gives power in itself.
I agree. It's a great point. You mentioned the Menopause Cafe in City and Hackney in that video. Why is community support or spaces like that as important as clinical treatment when you're managing symptoms?
Yeah, I mean, they're shared symptoms, aren't they? You know, and a lot of things people experience, whether they're men or women, are shared symptoms. And, you know, I have really tried to focus away from, you know, of course we have to manage disease, and that's a really important role. But I've also tried to really focus clinical care on symptom management. And there are some medical, you know, ways you can do that very, very effectively. And it's as important as treating disease, and much more, you know, there's a much bigger group of people who need symptom management. But part of symptom management is how you live with and perceive your symptoms, and how you understand the different ways that different people manage, and also just that sort of isolation living with symptoms is really difficult. So bringing people together with a shared experience, they can learn far more from each other than they can from me. I mean, I sometimes go into the cafe and I'll give them a bit of a medical spiel, and they find that very helpful. Of course they do. But also they meet very, very regularly, and I may maybe do that every 6 months. And the 5 other months, they're finding some very different things to talk about than I can ever offer.
So it's really conversations in those communities and those spaces that can happen in a doctor's office, or is it?
I'm just not sure the doctor's office is the right place. I mean, bringing sort of other experts into that space and taking the medical bits away, keeping them a bit separate. I mean, we could do it in a clinical environment, but I like the fact it's in a cafe, and it's called a menopause cafe, and it's a social space.
So what do women say to each other that they don't say to doctors?
I think that it's not that I think that they learn from each other's experiences, and I think they tell people what it's like day by day, and they chat, and, you know, as lots of women do, you know, very kind of, they enjoy a social space. And I think, you know, if you don't really know about menopause and it hits you in the face, then it can be very isolating. And often if you haven't got a family who also knows anything about it, you go to a place and you suddenly find, actually, it's everybody, not just me. And that's very empowering, I think.
But time to go upstream. What systemic changes are you leading to stop this at the source?
So I think there's trying to do quite a few things, but not too many, because, you know, I think once you're in a position, you really do, to make a difference, you actually have to have some key missions and some tangible outcomes, and you have to let some things go. And I think the things that are at my heart from what I've seen are about experiences not being heard and pain. So that's a really big bit of work that we're doing, trying to both help women to get what they need, but also trying to work with healthcare professionals to listen better and trying to manage pain better by prioritising things like pain relief for procedures that women go through. So that's one big part of work. The second thing that we're really trying to do, which is part of trying to shift waiting lists, but also we know community management is going to be, a multidisciplinary wraparound management is going to be better for women. And so trying to build on the new neighbourhoods programme to say, how does that serve women well? And what kind of models of care, can we have new models of care to change how things are approached? That's quite a big cultural shift. And then right upstream is really thinking about sort of empowerment education, challenging misinformation. How do we work better to use the tools that are coming through and to use tech and innovation and, you know, all things that are less my skill sets, to be honest, but really recognising that we have to, you know, we must go there because that is the key to really helping people to manage their health better, and we know that.
You pioneered women's health hubs in City and Hackney. What makes a hub different from a traditional clinic? And what problem were you trying to solve?
Yeah, so I think that sometimes when people think about hubs, they think about a shiny building where it's all singing or dancing. And I think it's more of a conceptual, I mean, one must have a building and a place for people to go, but it's not so much in the building in itself. So the problem really it was designed to solve was the disconnect between primary care and secondary care. So you might go to your GP, and there are many GPs who are really very interested in women's health and are able to give, you know, quite significant specialist care. For GPs, I feel for them because you know, you might be interested in diabetes or heart disease, and you can't be someone who's a specialist in everything. And we are kind of asking GPs to do that. And then the next sort of layer is if you can't manage as a GP, you refer into secondary care. So lots of people are ending up in hospital who don't really need to be there. And they're having disease excluded, but then they're still going away with their symptoms. So we're getting something wrong because that medical model isn't the right thing. So it's something in the middle, and I like to call it interface care, which is trying to match what the GP is able to offer with something a bit more specialist, but can still be managed in the community, and draws in pelvic physiotherapists, it draws in psychology, it draws in dietitians. So really trying to improve that wraparound care that people need.
I mean, and yeah, again, going to the holistic viewpoint and trying to empower people and not having them keep going back into the system. So what does seen faster in the right place first time actually mean for a woman walking in?
Yes. So I would hope that as a woman that you wouldn't know whether you were being seen in a hub or, you know, that you were just going to get the same level of care wherever you went. So for you, being seen in the GP might be the right place because you might have a relatively straightforward problem, or your GP might be a very expert in women's health. And then there is no better place. Or you might walk into a GP who isn't so familiar with your particular problem, and then you'll straightway be segued into a hub, and that might be towards someone like a physio, you know, so you might have an issue that needed a physio rather than a doctor. Or you might be triaged in a medical way, and then you might be also have a little bit of psychology, dietitian input, but also maybe some medical treatment. So the idea is that you get all those things you need, and you may also need a hospital. You might need to have something that couldn't be done in the community, or you might need to be on a surgical waiting list. And hopefully by doing this, we take the pressure off secondary care so they're freed up to do those things. That is much more a disease management service, which is about, you know, trying to do the surgery that's needed or do the more complex investigations that are needed.
For the first time ever, the NHS created a national role specifically for women's health, yours. Before this, women's health was basically reduced to gynecology and disease models. What does it mean that women's health is finally being taken seriously at the highest level?
So I do think this has been an important shift because we're, first of all, I mean, it has been very focused around reproductive health. And partly that's because, you know, it's the one thing that women experience that men don't, arguably. I mean, in a particular way, anyway. And then as we move on, of course, we're trying to see more the inequities that women experience. So that's much bigger than reproductive health. So starting to balloon out as a sort of inequalities issue, which I think, you know, there's always been inequalities lens, but often I think that the difference between men and women has not been brought too strongly into focus. So I think it's starting to enable us to shine a light on the other bits of care for women that has been neglected to date. And, you know, if you look, for example, at the waiting lists, they are much higher for women than they are for men. Now, a lot of that is gynecology, because gynecology waiting lists are big, but not all. So I think that, you know, if you put that all together, that's just an example of where women are being disadvantaged. Or if you see how, if women present with chest pain, for example, they're much more likely to have that diagnosed as an anxiety-related condition than a man who will be straight into hospital ECG. And so women's diagnosis of heart attacks for women is not very well made. You know, we miss a lot. So those kind of things we really do need to get a handle on and start sort of, taking a lead in those.
So what can you do now that couldn't be done before?
Yeah, I mean, I think having a system perspective is really, really important. So it is partly about how clinicians behave, but it isn't all that, is there? There's lots of things that enable care to be better. So I think it's working with what are we trying to change, and then how do we actually do it? Because rather than admiring the problem, it's actually getting in there and saying, actually, we need to do things. And there are some enabling things that we can do. And some of that will be around the workforce, but of course, some of it will be around digitisation. Some of it will be around information and education. You know, what happens to people at work, what happens to people in school. So it's working with all those different partners. We can't do it ourselves in healthcare, because my role is healthcare. But we can make sure that we link in so that the right things are being done to drive the change. And then, of course, we have to have a way of measuring change, because otherwise we never know whether we're making any difference. And I think there's nothing like a bit of progress to help say, OK, we're doing the right thing here, or we're not doing the right thing here, so we've got to make a change.
So both are helpful. But this kind of leadership, which involves, you know, influencing beyond authority, bringing people with you, you know, without having direct power. I mean, this matters to anyone trying to create change. So how do you do it? And, you know, whether you're a clinician trying to improve the department or a woman trying to be heard by her doctor, what's the secret?
Yeah, and I think I definitely wouldn't pretend to have the secret. And I think when you're a leader, you have to be very flexible. You kind of know the levers to pull, but when you pull them and where you pull them, I think varies. And so dipping into the kind of sort of power structures, but also reaching into people on the ground, the voluntary sector, women themselves, you know, like really shaping the change. So listening, finding out what that change that's needed is, and then helping, using your influence to pull things in the right direction. But it's very, you know, it can sound a little bit haphazard, and that's why it's really important to keep an eye on the mission and what you're trying to achieve in the outcome.
On October the 23rd, the government announced menopause screening will be incorporated into the NHS health checks for the first time. That's brilliant news. You were quoted saying, "Far too often women say their concerns aren't listened to." So tell me about your involvement. How did this come about?
So I think this has been gestating for a long time, and it's been sort of in and out, and I think it's, you know, a great, and again, it's that thing about timing, isn't it? So, you know, it's definitely been something that we've been talking about for a long time. And then sometimes these things just, you reach a critical moment and then they go, everything comes together. So we have the evidence, that's a good thing to do. We have the health check. We have a government who's listening and, you know, wants to make that change. And then along comes World Menopause Day, and here we are, you know. And sometimes these things happen, you know, they gather pace, and then you're, oh gosh, after all this time, this has happened. So I think it's a sort of, the lesson is to, it's often chipping away, and it can be very dull, and it doesn't all work, but, you just keep the mantra going, the drip, drip, drip. I think it's the drip effect, really, drip, drip, drip.
It adds
and then
up.
the
glass
gone.
is full.
Yeah.
And here we are now.
Exactly.
It's a brilliant thing for women. I just wanted to ask you, what will it actually mean for women walking into their GP surgery? What changes?
So I think it's just about, so we know that women who don't know about menopause actually are likely to suffer symptoms worse. So I think it's about democratizing that information so that every woman who walks through the door for their health check will also get information about something that they might not have got. So that's one important thing, although let's be aware that the health checks don't always reach everybody. So people who are often going to get their health checked are people who are already looking after their health. And actually what we want is people who maybe don't know so well how to look after their own health, or haven't used the system so well. So it's not going to be everything, but it's something. And I don't know exactly what that will look like. We will evolve the thing. But the other thing that's really important there is that some women have an early menopause. In fact, 5% of women have an early menopause. That's before 45. And those women are more at risk of poor bone health going forward, and that puts them more at risk of things like a hip fracture in later life. So I think it will be also very good in helping to identify women and say, well, what you need to do is take some vitamin D, you need to make sure that the calcium in your diet is good, you need to take plenty of exercise, and maybe you need to take HRT. And so I think that there's two important functions. One is an empowerment function, and one is a actually prevention function.
So, that's absolutely brilliant, Sue, because a woman might be going there, she'll have some questions asked, or she'll get some information about the menopause, but it actually can be more than that. She might find out that it might be a good idea for her to get a bone density check.
So I think that to begin with, it'll be a sort of signposting function. Okay. So I think that it will be a way of sort of saying, what does this person need? And for many people, it'll just be information. And then it will be, well, actually, I think maybe you need a bit more. So then pushing them in the right direction to get that help.
Yeah, but something that we didn't have before.
Exactly. It's really important.
And just on that same day, the government announced that the Women's Health Strategy, that's the NHS's first comprehensive plan for women's health across the entire life course, will be renewed. They're saying it'll focus on endometriosis, pain relief, something close to your heart during procedures, gynae waiting lists, things that women have been screaming about for years. And I wanted to ask you, what needs to be in the strategy that can't be left out?
Yeah. So that's the problem that is being grappled with, I think, is that how do we make a coherent strategy that's going to make a difference when we're talking about 51% of the population? That is very challenging. I think that it will certainly look at what's been achieved in the first strategy, what were the gaps in the first strategy, and what else can we do to amplify what's being done. And also, bringing it into line rather than a line, the 10-year plan. So, because those missions are absolutely, as I've said earlier, where it probably needs to be. So thinking, okay, how can we do that right for women? So,
Sue, I want to get personal for a moment, if I can. Beyond the policy and the systems, what drives you? What keeps you going?
Yeah, wow. I think that it's just a very strong sense of, my belief system, I guess my value system. I believe very strongly in reproductive rights. I believe very strongly in equity. So I suppose the work that I do, I feel very fortunate that I have a job that enables me to speak to those values and try and speak to those values. And I think, I feel grateful that I was chosen to do this leadership role and to bring those values into the system. So I kind of, not that they're not there already, but to contribute in that way. So I think that, I suspect I wasn't the most conventional choice in that I'm not a gynaecologist. I mean, I am a gynaecologist, but not a hospital gynaecologist. So I think, those are the values that drive me, a really strong belief that things should be better than they are.
I was going to ask you to tell me more about which values there are in particular, but it's just you'd like to see more, you feel...
I see more fairness. I mean, and I'd like to see, people, and I really have a passion in the NHS. I've never worked for any private sector organisation, nor never will.
So that is a value.
And that's a really strong value for me, and I have a very strong public sector belief. And I think, healthcare should be freely available. The NHS was built on those principles, yet at the moment, people are being driven into the private sector because they can't get what they want. And that feels like an injustice to me. And I really, really want to promote NHS values, and make sure my family are all we're very much passionate about social justice, I guess. And they don't work in the same things as me, but, they're all trying to strive for the same things. And I think collectively we find that very important.
As a family. So what is it that you might see that really gets you going, that upsets you? Is it that you think that's not right and that we have to do better?
Yes, well, we have to do better, don't we, at the things that are the fundamental rights of people to have, access to the basics, and, that's education, that's health, that's somewhere to live, all those things that are the things that drive me and my kin.
I love that. So what keeps you up at night? Not the policy stuff, the human stuff. What stays with you?
Well, I suppose people's personal stories. I think, so we can talk all these grand, can't we, like system leadership and all those things. But in the end, the things that stay are people's stories, and sometimes, most times, I hear a story that makes me feel sad. It might be someone who's just lonely. It might be someone who's had a difficult start in life, and those are the things that I still mind about. And I think that's important when you're seeing patients to say, do I still mind? Yes, I do, and that sounds a little bit pious. But, people's stories, I feel it's such a privilege, isn't it, to hear people's stories. And I like listening, I really like listening, and I feel a success if someone's shared something that they maybe didn't expect to share, and I can just sit and listen to that. And I think, as a doctor, we do more than just hand out, a couple of pills. I think we should do more. I believe that's a style of medicine that I have done okay at.
More than okay. Is there someone that you're thinking about in particular? I would love to hear a particular example of someone sharing something with you. They trusted you. An example?
There are so many stories of people who sit in my clinic, and have awful stories of being in an abusive relationship, or feeling very depressed, or having lost a family member, or having had a cancer diagnosis, or it's a lot about people's experiences and feelings, I guess, and we don't ever measure the impact in that way. And of course that's a luxury of time. In health and healthcare, we have to remember that we still need to be efficient. And so I suppose when I go back to the system issues and I think about how can we make pathways more efficient, what I mean also is freeing up more space to do some of that other stuff, as well as getting the treatments right.
Mm-hmm, mm-hmm. I've heard the word listen and listening a couple of times in our conversation. How do you feel just being there and listening to people who are sharing these very vulnerable moments? How does that help, do you think?
I think sometimes that people just naming their issues and having someone hear them and take them seriously is a little bit towards them being managed in a different way. And I don't think that we take enough notice of that. and it isn't enough in itself. Of course it's not. But I think that medicine has cultivated us towards getting things done quickly, getting the right treatment, not making a mistake, for very good reasons, you know. But sometimes those bits, the softer bits, have been lost because they're not measurable.
What about if you could design a woman's health system from scratch with a blank slate, no constraints, no legacy systems? What would that look like? What do women actually even really need?
Well, I don't think I could even, you know, I suppose if I was going to do that, what would I do? I'd put the right women in the room to do it, you know, and I think that the point is not to say this is what the right system is. If you really had that opportunity, wouldn't you want women to design it for themselves, you know?
Yes.
And, you know, I would probably try and put the people who are served the least well so far. What would you do to be served better, and then to layer on top of that what else we need? And there's an interesting study from the Institute of Child Health. There was someone called Anthony Costello who was did a lot of work in Nepal and different countries about how do we reduce maternal mortality. And he got together some women's groups, and his intervention was women's groups. He didn't say what the intervention was. They themselves collectively decided how they were going to improve their outcomes. And just by having the women's groups, improved the outcomes in terms of maternal mortality. So those women did very different things, but they knew what was best for them in order for their outcomes to be improved. And I think there's a lot of learning for us from that.
Having the right people around the table and let them co-create what's best for them. Just give them that space. So what's the one thing you could change today that would get us closest to that kind of vision?
Yes, I mean, it's, I think, to involve women more, because, you know, we have to recognise that we are where we are. We can't just scrap the system, and we have to double run sometimes to make change happen, and it's expensive and difficult. But if we don't get the right people in the room, and it's not always women, is it? It's, you know, it's sometimes men, it's sometimes particular groups. But if we're not asking them to at least, you know, sense check, but better actually design the new systems that we're trying to build, then we are making a very, very early mistake.
What's your advice for women who feel their concerns aren't being heard in healthcare? How could they advocate for themselves effectively?
So I think there's increasing amounts of information out there, isn't there? And so trying to help them to reach the right information. I think we're in a bit of a difficult situation because we're playing catch up with, you know, the entrepreneurs who are creating that information and the social influencers. So trying to help them to access the information that's most accurate, most up to date, is our job. And, you know, informing themselves. But I as I say that, I realise that, you know, for some women that's very straightforward, and for others it's not.
So I just wanted to ask you, what's the one thing that women should do to prepare for an appointment?
Yeah, I mean, I think that's really difficult, isn't it? Because, you know, often people are going to an appointment, they don't really know what the problem is, and it's a bit chicken and egg. There are some really good resources out there preparing for an appointment. So there are some, for example, there is something on the Wellbeing of Women website, which is a menstrual health checklist, and it helps people to answer questions about their periods, and then it generates a letter for their GP, actually, so they can go along waving the letter. So that's just one good example of looking out for things. I think there's plenty of things out there. What should I be asking my doctor? But I think if you've just taken the time to think a little bit about what you want to say, that's all good, and what you hope to get out of the consultation, because sometimes you won't have very much time. So what would good look like for you when you left that appointment? Because I think lots of people say, oh, but they didn't really answer my question, or I didn't get what I needed. The NHS website, I think, is pretty good, actually. So looking up a problem on there and getting the measure of what the treatment options is good. Those were the main things I would suggest.
Well, that's sound advice, and again, empowering, which is something that you're a big advocate of. So as we come toward the end of our conversation, I want to ask you about the wisdom that you want to leave behind. But before I do that, you're just recently become a grandmother.
I have.
What's that
terrifying? Like? Terrifying age-wise, but absolutely lovely. I mean, you know, watching my daughter be a mother, I think, has been a very kind of moving experience, and she and I are very close, so that has been wonderful. And And yeah, just sort of, it's easier to be a grandmother than a parent, because you can take a bit of a stand back and sort of not feel quite so responsible. So that's all nice. I mean, she did, and maybe it's a good point to raise, but she had a difficult birth experience. And I think for me, that was very difficult to watch, but it also really reinforced a lot of what I'm saying, because a lot of the difficulties, yes, there were some physical difficulties and complications, and they're both absolutely fine, but actually the difficulties arose from sort of institutional structures, poor communication with her, and sort of leaving her feeling not heard. And her fears not having been addressed. And actually, the thing that she walked away with that she carried was not the hemorrhage that she'd had, but more how she'd been made to feel. And I think that was such a lesson for me. And it was so like, we have to do something about this, you know. So, you know, it was harsh, but very important, I think, for me.
Well, I'm really sorry to hear that. That doesn't sound
And
like
they're
the
fine.
best.
Yeah.
I'm glad that's the main thing. But that you're bringing that yet another
Yeah.
lens, that lived experience very close to you to help you continue pushing for, you know, the right things to be done. I also wanted to bring out another point, because before we started recording, something that you said that really struck me. You said, I'm too old to be a people pleaser. If I lose my job standing up for what's right, I'll be proud. I mean, I love that. That's so powerful. Tell me about that shift. I mean, when did that happen for you?
Yeah, I mean, I think that's quite a grand statement, isn't it? I think what I'm trying to say is that I will continue to stand up for my principles, and I feel confident that my principles are true to me, and I think reasonably good, not particularly, you know, controversial in some way. But I think if in the course of my work something challenged my principles so fundamentally, then I would continue to stand by them, regardless.
That's amazing. I think we got the right person in the role. What would you have been too scared to say 20 years ago that you will say now?
I think, you know, challenging authority 20 years ago would have been very difficult, but now I wouldn't bat an eyelid, really. I don't see those hierarchies at all in the same way. I just, you know, we're all on equal pegging, aren't we, or not, you know. But I think I'm also very aware of hierarchies, and I think, you know, I want to make sure that people, I love bringing people up who are younger. You know, I've got some brilliant young leaders who have so much to say and contribute, and, you know, call me to account.
Tell me more. That sounds amazing.
Yeah, I mean, just, you know, lots of people who come through, they come and do attachments with me, they want to be part of things, they want to be involved in projects, you know, and I can't get enough of them, you know. I've some brilliant young women who will be great leaders in the future.
And it sounds like it's very energizing to you as well. This podcast is Women Leaders, Tales, Trails, and Truths. So we've covered your tale, that's that river metaphor you beautifully described. We've covered your trail, so your journey treating individual patients, to becoming the NHS's first ever National Clinical Director for Women's Health, and from mother to grandmother. So what's the truth? What do you want women listening to know? And what about Ari's generation? What's the truth for them?
So I suppose what I want women to know is that we are committed to getting it right for everybody. And I honestly think that if we get it right for the people who are least well served now, we will get it right for everybody. So that's the kind of message, is really we're working hard to do that. And I think, you know, for the new generation of people coming up, I mean, Ari's 7 months old, so, but I've already got some ideas. And I'm glad he's a boy. Because, you know, I want to, our young boys and men, you know, we need to help them, don't we, to really, we need to be much better at exchanging knowledge. We're not two kind of different species, are we? So really helping him to be able to have conversations between boys and girls and men and women and learn about each other's experiences and not see them as threatening. So I think so much of this happens in schools and in early experience. So really want to kind of make sure that happens. I suppose it really comes down to the democratization of knowledge, which I mentioned earlier, which I think is so important.
Which is a value of yours as well. Just one final thing before we finish. Can you give me one sentence, perhaps your legacy sentence, that one truth that you want carved in stone? What could that be?
If we make things better for the least well served, we make them better for everyone.
That's brilliant. So I can't thank you enough for being here, for your honesty, your passion, for everything that you're doing to change women's health. We're so, so grateful. Thank you so much.
Oh, thank you for having me.